Hello class. In this presentation we're going to discuss some different variety of spinal trauma. First of all, let's look at some of the important learning outcomes. When you approach cervical trauma, you need to obviously understand what type of injury, whether they're stable or unstable, and obviously a type of management and potential complications. So the important thing obviously to understand functional anatomy of the cervical spine and how it's going to potentially predispose to some of the injuries. In general, we can also consider some of the important topics following these topics. We will consider arthritic disorders, neoplasm and infection, and look briefly at post-surgical spine. So let's start with just very brief general anatomy, hopefully just anatomy review. Cervical spine obviously is different in the fact that mobility of cervical spine is significantly being sacrificed for its stability. You can see the vertebral body sizes are usually quite small. In addition, it's interrupted by multiple foramina. The size of the spinal canal is obviously much larger. In a vertebral, the lamina are usually quite thin, and not much of a transverse processes, and spinous process is usually shortened by fit. That's in a typical cervical vertebra. Now you can also see a relatively large facet, articular pillar forming facet joints. So the bottom line to understand that that cervical spine is actually susceptible to injury. So therefore, just by its anatomical arrangement, to some degree, it's predisposed to potential fractures and dislocation. Another important thing to appreciate, obviously, for upper cervical spine complexes is provide major stability, including the majority of rotatory movement in the cervical spine actually occurs between C1 and C2. In addition, C1 vertebra is really just a thin lamina of bone that's been sort of like squeezed between the large occiput and the weight of the head, being sort of viced or squeezed between C2, which is relatively large and considered to be actually the largest cervical vertebra. So in addition, any form of axial trauma will predispose C1 vertebra to potential fractures and dislocation. On top of that, ligamentous restraints that play a significant role, particularly transverse band, may be significantly compromised. So another good picture just to sort of familiarize with the anatomy of the cervical spine and understand how it can predispose to potential fractures, dislocations, and other complications. Now, another thing to actually understand that apart from a large neurological structure, spinal cord, that's usually largest in this region, you also have your foramina transversalis that transmits vertebral arteries. So therefore, potential cervical trauma may also interfere with some of the posterior cerebral circulation. Let's look at cervical trauma. So the important thing to obviously appreciate stability. And obviously we know, as I mentioned to you, that mobility is being sacrificed for its stability. Another important thing to understand that in general, cervical spine is obviously relatively small, narrow, and very flexible, that has to carry a significantly large head. The head weighs close to 5 or 6 kilograms, and also you have relatively rigid torso. So as a result of that, any form of injury, that significant kind of some kind of high energy trauma, may potentially compromise stability of the spine. Another important thing to appreciate is the difference between pediatric and adult spine. So we know that in children, ligaments are usually more lax than in adult. The spine is still maturing, it's kind of mainly cartilaginous, but also size of the head is much larger. So therefore, pediatric trauma should be also considered as a major sort of potential major compromise to the cervical spine and neurological structures. In addition, in children, due to high flexibility of cervical spine and the fact that the ligaments are relatively lax, you may experience a potential situation known as Sewara syndrome, or what it stands for is actually spinal cord injury without radiographic abnormality. In other words, you may not be able to note significant fracture or dislocation, but your child, on the other hand, may have significant neurological compromise. In adults, as we know, fulcrum, sort of during flexion and extension movement, particularly hyperflexion, there may be significant impact, particularly on C5 and C6, or rather lower cervical spine. In children, on the other hand, those fulcrum tend to affect mainly upper cervical spine. So let's consider there's a classification known as Harris and Mavis, but when we look at cervical spine, it's important to consider a mechanism of injury, and it's generally considered as injury, potentially hyperflexion injury, hyperextension injury, and axial loading injury. In addition, there might be some rotatory component to it, and so on. So let's look at some of the significant trauma. Typically, let's look at important steps when you approach your cervical trauma. So obviously history is very important. You need to examine the patient, and particularly certain criteria exist, something that is nexus criteria that actually determines if there might be underlying significant trauma to cervical spine. Now, the important thing that physical examination is important. For instance, midline tenderness, a significant red flag if the patient was intoxicated, and the fact that they potentially have some neurological signs and symptoms such as paresthesia, Lemaitre phenomenon, but also, if they have significant sort of deterioration of sensation, pain, etc. So major neurological complications. So what's the imaging step? In most cases, you may begin with plain film radiography, and that's usually not the end point. Plain film radiography just helps you to kind of exclude if there is a major trauma involved, especially in low probability of significant injury. But in some of the cases, if radiographs are not rewarding, or they kind of equivocal, and even if radiographs show significant trauma, in most cases CT scanning without contrast is indicated to evaluate cervical trauma. And in addition to that, it may also be CT scanning. Whilst CT scanning is being performed, you can also obtain head CT slices, and that can determine also possibility of head injury. Now, if there's significant neurological complication present, later on MR imaging might be helpful, but certainly MR is not the initial modality of investigating cervical trauma. Now, another thing important to appreciate during cervical trauma, in some patients with so-called rigid spine changes, for instance, patient with spondylosis, degenerative changes, patient with DISH, ankylosing spondylitis, instability due to RA, post-surgical spine, and multiple types of congenital abnormalities such as blocked vertebral or Klippel-Feil syndrome and others, all those may predispose that cervical spine to it becomes much more susceptible to injuries. So these are just general kind of radiographic views. So you obtain 3 views, and you always start with neutral lateral. So you try to clear neutral lateral first. That actually allows you to investigate for any major sort of violations of alignment, soft tissue changes, etc. Then you perform AP lower cervical, and in addition, it's very important to evaluate C1, C2 relationship, particularly looking at the alignment of the odontoid process, articular pillar orientation in relation to C2, and some other changes. So how do we approach that? So a couple of nice images for you to appreciate. So here's the nice picture for you to radiograph to actually show. So when you approach your alignment, you need to actually physically construct those lines and make sure there's no interruption. So anterior vertebral line, posterior vertebral line, also known as George's line. Then you carefully look at the spine alignment line and connect also SPs, but also look at the alignment of facets. Another key feature for you to appreciate is significant disruption of some of the ligaments, annular fibers on the posterior aspect, or in capsular ligaments, or some of the interspinous ligaments or flavum ligaments, is to see if there's any significant widening of the disc posteriorly. Usually the disc should kind of taper posterior, and you don't expect any kind of abnormal widening. In addition, any abnormal fanning or widening of the SPs may also represent significant trauma. Another very important feature for you to look at is the soft tissue swelling. Typically, soft tissues around C5, so rather C6 and C7 should not exceed 2 centimeters. In other words, the upper limit of normal should be 22 millimeters. At C2, they're usually 7 millimeters upper limit of normal. Another important feature, you obviously look at ADI, atlantodental interspace, that in adults should never exceed 3 millimeters, and usually at about 2.5. Now in children, it can be a little bit, upper limit can be a little bit greater, so usually 5 millimeters and no more than that. In addition, on movement, if you perform stress views in adults, you don't expect any increase or decrease of the atlantodental interspace. In children, on the other hand, it may be possible by a couple of millimeters. So there's a present system that actually helps you to predict whether spinal injuries are stable or unstable, and that's actually based on something that is Dennis classification. So if you look at this diagram, it kind of divides your spinal column into 3 separate columns. So the anterior column actually comprises of the 2/3 of the vertebral body connected by an annular fibrous and anterior longitudinal ligament. The middle column is the remaining third of the vertebra, posterior longitudinal ligament, and the annulus. And the column number 3 is the rest of this posterior elements, all the spinal ligaments. Now the key to understand that you require 2 out of 3 columns to be intact to provide stability to the spine. So therefore, when you observe some of the fractures and dislocations in the cervical spine, or anywhere in the spine in fact, you should evaluate that. And if it involves only a single column, then in that case, spinal trauma may be considered as stable. So let's look at important fractures that actually affect acute trauma that affects cervical spine. So this fracture known as in hypoflexion injury, this fracture known as flexion teardrop fracture, and in trauma it's actually considered the one of the dreaded fracture of the cervical of the spinal column. And the mechanism is usually hypoflexion, usually car accident or perhaps falls, or maybe some sort of significant sort of flexion injury when the patient falls, or rather diving into shallow waters, etc. So the key to understand, so radiographic features, you typically observe a large osseous fragment, and that's hence the name teardrop, usually triangular tear shape teardrop fragment. But the important thing to appreciate in this case, why that makes this injury so unstable, is there's a fanning of the interspinous processes. There's also some, you can see, widening of the facets. But the important thing what also occurred, there's a complete fracture and disruption of all the posterior ligaments, including vertebral ligaments, which usually results with posterior displacement or retropulsion of the posterior remaining part of the body into the spinal canal. Therefore, for that reason, it's highly unstable fracture, and it results in the majority of cases, patients will be paralyzed on the spot of the accident. And that's another example of flexion teardrop. As you can see, a couple of questions you may be able to answer. What are the significant key radiographic features? And in this case, what I'd like you to note is you can see that fanning of the interspinous processes, separation between facets, obviously teardrop fragment itself, but also in addition to that, those, particularly this fanning and then the separation of the facets, that indicates that there's a significant disruption of tearing of the posterior ligaments in the spine, making that injury highly unstable. And that's another good example. On CT scanning with sagittal slices reconstruction, you can see that flexion teardrop fracture, and a picture manifestation demonstrating how spinal cord injury can occur. Multiple mechanisms, the instability itself, but also that posterior displacement of the vertebral fragment can actually directly compromise both spinal cord itself, but also vascular structures such as spinal arteries, leading to significant ischemia, edema, and potential paralysis of the spinal cord. MR imaging. In this case, you can see sagittally reconstructed T2 weighted imaging. You can see flexion teardrop fracture with some kind of teardrop fragment indicating fracture itself, but also you can see posterior displacement. There's a sort of sudden kyphotic deformity that we usually see. That's another additional feature both on plain film, CT or MR. And you can see some fanning or widening of interspinal spaces with significant edema in that area. In addition, you can see a large high signal intensity in the cord with some areas of low signal indicating edema and probably some sort of necrosis, post-ischemic sort of changes in the cord. So this person likely to be paralyzed from that point down. So anywhere from C3 down, potentially you can experience some paralysis. Now, important thing, this is a little bit unusual because most of flexion teardrop fracture occur from C5 down to C7. However, it can happen if the fulcrum of forces kind of tend to affect that area. The other thing to appreciate, like I said, that apart from that directly spinal cord injury, you may have vascular complications, but also if at that level, phrenic nerve paralysis may also be encountered. Another hyperflexion injury is going to be facet dislocation, where, for instance, fracture may not be so readily demonstrated. And in this case, you should be able to differentiate between bilateral and unilateral facet dislocation. Now, when you approach that bilateral facet dislocation, typically what you notice that the dislocated part, so the facets obviously overlap, that's a key significant feature. Remember, if I mentioned to you that you always approach neutrolateral examination first before you even undertake any other views. So you clear that first, and for major instability, that's one of the reasons. So in this case, what you should also observe with bilateral facet dislocation, what makes that diagnosis to be bilateral facet dislocation, is that the vertebra above actually translated or displaced anteriorly 50% or more on the vertebra below. And that's usually bilateral flexion injury without any potential rotation. Now, on occasion, obviously, you can understand that it's significantly compromises spinal canal. If your canal expected to be here, that's your basically lamina, that's where spinal canal, spinal cord is. So you can see that significantly disturbed in relation to this spinal lamina line. So there's a sudden acute post-traumatic stenosis of the canal, and it may lead to significant neurological complications. Now, another injury may occur sometimes. You can see that this part of displacement is not significant, so it may be unilateral facet dislocation, which is also a very unstable injury, but may be occurring sometimes with bilateral, with a component of flexion and rotation. Now, in this case, occasionally when facets are sort of, let's say, contact very tip, sort of the communication between facets at the very tip, they occasionally call this perched facets. In this case, again, it's still a highly unstable injury, and the person needs to be, usually neurosurgically evaluated for treatment. In this case, you can see that posterior elements are also being torn, posterior ligaments, because there's significant widening of the lamina space and fanning between the SPs, so typically flavum and interspinous ligaments, but also capsular ligaments are being torn, even though there's no significant displacement of the anterior body forward. That's another example of bilateral facet dislocation. You can see on CT scanning reconstructed imaging. In many cases, CT scanning will be required even if radiographic diagnosis is readily available. Now, in this case, you can see complications of bilateral facet dislocation. You can see significant spinal canal stenosis with very extensive high signal intensity. This is fluid sensitive study T2, high signal intensity within the spinal cord with significant anterior displacement of the vertebral body and significant kind of angulation and sort of compression of the spinal cord. So again, requiring neurosurgical evaluation. And indeed, because of the significant injury, these people will be predisposed. There's laxity of ligaments, so they may actually undergo some kind of cervical fusion following that. Now, unilateral facet dislocation, again, findings can be a little bit more subtle, and in this case, what you note that typically there's no anterior displacement of the vertebral body 50%. So usually it's less than 50%. But what you do note that there's incomplete sort of overlap and then significant rotation. So in other words, the facets may appear as if they're kind of out of focus. There's blurring in the facet. So the suddenness of that blurring may typically suggest that unilateral facet dislocation, including, as you note, also widening and disruption of posterior elements there, indicating significant injury. Now on the frontal view, you can see there's a sudden misalignment of the SPs. So in other words, you can see the spine SPs that usually should form a nice continuous line. At that level, they sort of suddenly disrupted. That may also indicate sudden rotation and usually suggestive of unilateral facet dislocation with rotatory component. Now, hyperextension injury in the cervical spine typically involve again, predictable trauma. In this case, one of the important injuries due to hyperextension when the fulcrum occurs somewhere in the upper cervical spine. So what you find that a fracture known as hangman fracture, sort of by the eponym name is sort of derived from sort of judicial execution, when there's a sudden hyperextension induced by sort of a rope or a knot of the rope placed under the chin. So it's really just an acute hyperextension injury that usually results with disruption. It's a nice picture to show you disruption of the annular fibers, and usually a fracture that may sort of pass through either pars interarticularis, but fracture may also affect sometimes the pedicle too. So different types, usually 3 types described, but what you actually find that posterior elements within this fracture actually usually move posteriorly, and the anterior parts of that fracture will be kind of tilted and move anterior to, and also this fracture as a result of that is actually known as traumatic spondylolisthesis of C2. Now the interesting thing about this fracture, although it's highly unstable, it actually leads to only about 25% of patients may present with neurological complications. And the reason for that, because spinal fragments dissociate, so to speak, and therefore in reality it actually widens the spinal canal, potentially minimizing the risk of acute spinal cord trauma. However, this fracture is still very unstable and requires CT imaging and neurosurgical evaluation. And that's just a radiographic. So typically you see a fracture line extending through the pars with anterior translation or spondylolisthesis of the remaining body of C2, and usually it occurs in C2, and also sort of posterior displacement of posterior elements. Now another thing to remember with this fracture, because of acute hyperextension injury, sometimes there might be an avulsion or something called an extension teardrop induced by avulsion of the anterior longitudinal ligament, and it can be at C2 or C3 and less frequently at C4, but we don't see it here. However, on the next slide we may be able to observe it in this picture as one of the potential complications of that. So as you can see, hangman fracture right there. You can also see potential extension teardrop, and due to hyperextension the cord occasionally can be squeezed, especially if the person has some degenerative changes like it shows here. You can see some thickening of the ligamentum flavum, or rather buckling, and that may potentially narrow the cord, rather can create a canal stenosis, and potentially can kind of induce a sudden ischemic changes, mainly in the center of the cord, therefore being named as central cord syndrome. Now that may occur even without fracture. So you can see hyperextension injury, especially in spondylotic spine, sometimes can be observed as sort of central cord syndrome without any fracture. So just to follow that, you can see extension teardrop fracture. The mechanism, it's usually avulsion by the anterior longitudinal ligament, and in this case usually compared to flexion teardrop, you can see the fragment is a lot less, it's a lot smaller, and there's no significant disruption of posterior elements. So usually it's considered a stable injury since it affects only a single column. However, sometimes it's described as being unstable if you put that spine in extension. But overall, it's a stable injury. But if detection of this injury and X-ray or CT scanning should also necessitate further imaging, and in this case, CT may reveal some other abnormalities if they're present. On occasion, hyperextension will induce facet trauma, in other words, fracture of the facet, but possibility of other injury may occur. So in this radiograph, you can see on the lateral just a very subtle fracture fragment can be observed. Axial compression fractures. So in this case, fracture that is known as a Jefferson fracture. Jefferson fracture was first described by a British neurosurgeon in '50, and this actually involves a pure axial compression where C1 undergoes sort of like a burst mechanism. So it's typically known as a burst fracture of C1, and it occurs at very predictable location, usually through those areas of some sort of cartilaginous growth of the C1 vertebra. Because C1 is an articular ring, osseous and articular ring, as we already know that the ring itself will never kind of break in one spot, because the forces may be distributed all around it, and therefore, especially with Jefferson fracture, if you can go to this slide, you may see that the fracture itself occurs more than a single break. Therefore, it should be evaluated by CT scanning. However, X-rays can be adequate in demonstrating this fracture. So typically, APOM view is the most valuable in this case. And as you can see, what you find is actually disruption or the overhanging or overlapping, basically, of the lateral displacement of the articular masses of C1, and that occurred because the fracture itself is a burst fracture, so the fragments will dissociate. On top of that, you can also see obviously some atlantodental interspace widening, the sort of lateral atlantodental interspace. Now, the key feature to understand, if you measure this distance from the C1 articular mass to C2, and if that distance combined sort of exceeds 5 millimeters or 6 millimeters, that's usually radiographically on X-ray indicates disruption or tearing of the transverse ligament of C1, which actually necessitated different care. So usually it's treated with hard collar if transverse ligament is intact, and with halo brace if transverse ligament is torn. But like I mentioned, like I said, CT scanning is essential for diagnosis. In this case, you can see CT scanning was performed, and you can see some sort of complex fracture also potentially extending, affecting this area of the articular mass of C1 and extending in the foramen transversarium. So this person may also require perhaps magnetic resonance imaging, or particularly magnetic resonance angiography, or even CT angiography to evaluate vertebral artery, or in fact even just contrast given following this finding, just contrast administration CT will potentially demonstrate injury or thrombosis, post-traumatic thrombosis of the vertebral artery. Now, a few miscellaneous fractures, the mechanism may be combined, variable. So usually fracture odontoid process is known, and this classification exists as something known as Anderson and D'Alonso classification. Usually it describes 3 types of potential fractures of the odontoid process. The most common type is actually type 2. Now, the key feature about type 2 that the fracture usually occurs at the base of the odontoid process. Now, I should say for all of these fractures of odontoid process, CT scanning, plain field, but CT scanning is much more informative. You may see certain changes in CT, but they can be subtle. But we can look at that and hopefully learn a little bit how to understand the radiographic findings of the fracture. So type 2 fracture usually involves a junction between typically base of the odontoid process joining the body, and this one is considered to be the most common fracture of the odontoid process. On top of that, because it's most common, it also actually has least favorable healing potential. Why? Because this region, this zone between the C1 and C2 junction, between the odontoid process and the body of C2 junction, is actually not as well vascularized as the remaining big part of the body. Therefore, because of lack of hematoma and significant bleeding after fracture, it's known for its non-union. Most of this fracture occur in older people. So if you note C3 fractures, so typically it extends into the vertebral body, and therefore it has best healing prognosis. And C1 fracture is less frequent, but the difference between C1, type 1, type 2, and type 3 is that with type 1 fracture, it's usually understood as being a avulsion type fracture by a ligament, and some of those sort of apical ligament, but alar ligament, which may produce a characteristic kind of piece of bone right at the very top of the odontoid process. So once again, type 2 odontoid fracture is most common, but at the same time has most complication primarily as non-union. Let's look at the imaging. So this one, you can see it's a base of the odontoid process, and that was on the coronal slices and sagittal slices, and that indicates potentially type 2 fracture. So again, usually they should be evaluated. Treatment variable, but to prevent non-union, so usually hard collar. But if there's significant sort of displacement or significant compromise and non-union anticipated, so surgical care. Now, there are a few variations, so-called mimickers, that may present sometimes diagnostic dilemma. So, for instance, pediatric spine obviously is very different to adult spine. So there are a few variables that we should be aware and not to misdiagnose it as fracture. For instance, or any kind of ligamentous disruption. For instance, we know that ADI is usually larger in children, so up to 5 millimeters, and it can increase or decrease on movement by 1 or 2 millimeters. Now, the other thing is something called pseudo-subluxation. It is a completely normal relationship between C2 and C3, so it should not be interpreted as any form of sort of anterior displacement of C2. So that's another typical kind of mimicker of some kind of instability. The important feature that on AP open mouth, this is completely normal for pediatric relationship of C1 articular masses to be a little bit more overlapping or overhanging of C2. Now, of course, in adult, that should be considered as highly abnormal because we anticipate adult complete alignment between C1 and C2. Now, a few other things can be considered. As you can see in there, is basically a line of the incisors should not be interpreted as some sort of fracture or crack. And another line, as you can see, there's a line here demonstrated, is a known so-called MAC effect. That is just summation of densities that may produce sort of fake impression of a radiolucent line. So the typical pitfalls. The other thing is sort of different types of normal kind of ossification of the different parts of the atlas should also be considered as completely normal, because we can see that they're very well corticated. There's no acute type of fracture, and they develop, rather they're present at the very predictable location. Those are your normally sort of developmental changes that usually exist in a pediatric spine. Now, the important differential diagnosis is something known as ossiculum terminale that should not be confused with type 1 fracture, as well as ossodontoideum. So this is ossiculum terminale, as you can see there, ossiculum terminale, and ossodontoideum. It's another normal variant. You can see that the, in fact, it's considered to be sort of probably some sort of unnoticed, very young, early pediatric injury. However, in most cases, it can be stable, but it can be potentially unstable. This patient should be evaluated with flex and extended view. But the bottom line, it should not be confused with any sort of fracture odontoid process. You can see the spaces between them is much greater, and then you can see that the spine, the vertebra itself has been well corticated. That excludes sort of acute injury, same as here, that ossicle has been well corticated, and that usually speaks for more congenital type anomaly rather than a fracture. And a few other kind of incomplete ossification of posterior arch should also be considered as normal variant and should not be confused with any fracture. Now, another important thing in some patients, particularly Down syndrome, there is an abnormality that kind of results in laxity of their connective tissue, and in this case the ligaments between C1 and C2 remain quite laxed, and in fact it's a very significant contraindication for any manipulative treatment, any kind of spinal manipulation in those cases. And again, in cases of trauma, it should be treated as suspicious, but may not represent sort of acute ligamentous tearing or laxity in this case. Let's look at other injury. In this case, we look at possibility of rather fracture affecting thoracolumbar spine. So thoracolumbar spine you may have stable and unstable injury. So if you're talking about unstable injury, in this case something known as burst fracture. So the mechanism could be acute flexion resulting with sudden compression of the vertebral body and forces really forcing sort of vertebral fragments, and they dissociate, sort of leading to burst fracture. Now that's considered to be very unstable injury. As you can appreciate, it involves two-column system, and posterior elements of the posterior fragments of the vertebral body will retropulse back, and that can acutely narrow that spinal canal, leading to acute canal stenosis. In addition, another clue, there's a significant soft tissue swelling, and also another clue that we actually can observe on the frontal view is the widening, sudden acute widening, or widening of the interpedicular distance. It can be observed on this image as well, at about L2 level, and in this case as well. So you can see that a relationship between pedicles should be carefully observed, and in this case you can see that sudden interpedicular widening. So radiographically, when you combine that and the frontal view and the lateral, that may indicate a burst fracture. Now we can appreciate the fact that if burst fractures occur somewhere within thoracolumbar spine, spinal cord can be damaged, particularly its terminal area, particularly that conus medullaris injury, and may still result with potential paralysis of the lower extremity and other neurological complications. CT scanning is important, and CT scanning indicates, in this case, you can see on axial slices how vertebral fragments kind of retropulse back, significantly narrow that spinal canal, including the fact that actual bony fragments themselves, they can induce injury to the spinal cord, as it's sort of shown in here. Hence, a sequela, a spinal fusion, was performed for that patient. Now again, sometimes management can be conservative if patients don't show any kind of neurological complications. But once again, if any kind of neurological complications, so significant instability present, spinal fusion. Now another unstable injury is something known as chance fracture. In this case, you can see that patient is an 8-year-old female that had a trampoline accident. So if you approach this radiographic view, what would you observe? In this case, you can see a sudden wedging, a sudden kind of angulation of that vertebral body. But the important thing is to appreciate that the posterior vertebral line is disrupted. You can see that there's some potential retropulsion in the fragment. And when you pay attention carefully, you can see how the radiolucent line actually extends through the posterior elements. In addition, you can see the significant widening of the interspinous distance between posterior elements. So in this case, CT scanning is important, and CT scanning was performed, and you can see that it's significant extension through the posterior elements. So the fracture is something known as chance fracture, also known as fulcrum or seatbelt fracture. And then the reason for that fracture is acute hyperflexion injury, and typically could be a result of the fault or car accidents, and it has its name associated when during sort of lap seat belts, during acute injury, it may induce that sort of like a shearing type force, by which mechanism it could actually create fracture extending both the vertebral body and posterior elements. Now, if it can also lead to significant neurological complication and should be evaluated by CT and MR imaging. And in this case, you can see MR imaging was performed, and you can see there's some just enough to kind of compromise the lower kind of parts of the cord, because that's your conus medullaris. And in this case, you can see potential injury extending through the posterior elements and the vertebral body. So a diagnosis of chance fracture with potential neurological complication is slight cord compression may be observed in here as well. That's another example of chance fracture. You can see how it occurs, acute compression, and then basically kind of distraction type force that may result in complete fracture through the posterior elements, both pedicles, but also spinous processes and the lamina. Again, resulting significant instability and potential if it's at the level of the spinal cord, even cases describe of transection of the spinal cord and further paralysis. In this case, you can see that fracture extending through the posterior elements. For additional resources, there's some excellent information online, so I recommend to use all these articles from Medscape, eMedicine, and also Manifestation of Spinal Trauma, rather radiographic approach to spinal trauma, from articles from the American Academy of Family Physician. Thank you very much.